Congratulations, Derek, on the launch of your latest report, Saving 85,000 Lives in Sri Lanka. Can you please talk us through the report's methodology and key findings?
Yes, thanks, Jessica. First, the rationale for the study was that we believe that it's important to ask questions of what if, the counterfactual. What if we were to implement the best policies? What would happen to the long-term impacts of tobacco? This approach of doing what ifs have been applied in economics, have been applied in politics, have been applied in other areas of health, and they often are a means of motivating policymakers to see that with a small shift in policy, it can have a big impact on the population. And that's what we did with regard to Sri Lanka. We started off by looking at what are the current trends in the major causes of death, the smoking rates, the uses of tobacco, and what are we likely to see if the WHO Framework Convention set of strategies were applied over the next 20, 30 years. It's clear that there has been a slow, steady decline in smoking rates and the use of toxic oral tobacco products. We think that should go faster. So, with a group of experts representing deep insights into Sri Lanka, Asia, and the rest of the world, and built upon some of the best modeling approaches being taken in the West, we really asked the question of, first of all, what is the estimate WHO puts on 2060 deaths from tobacco? Second of all, what would happen if we were to increase tobacco harm reduction by a reasonable rate over the next few decades? And if we were to add to that smoking cessation, recognizing that there's been a very slow progress in access to smoking cessation, and then added in finally for the last few decades, over the next few decades, a steady improvement in lung cancer survival, recognizing that lung cancer accounts for a quarter of the tobacco deaths worldwide, as well as an important number in Sri Lanka. When we looked at that overall, we found that about 85,000 lives would be saved beyond those expected from WHO's policies. And that's off a current smoking base of about 18% of men smoking, about 0.2 to 0.5% of women smoking. But those figures, unfortunately, do not include the relatively high percentage of people who use a range of toxic oral tobacco products. In fact, Sri Lanka is one of the countries that exports areca nut, which gets combined with tobacco and a betel leaf and gets chewed in the mouth, causing very high levels of oral cancer, not uncommon across the whole of South Asia, tragically. By 2060, WHO estimates there will be about 8,000 tobacco-related deaths every year. Through our approach, we believe the number can come down to about 3,500. And that's how we eventually get, if you multiply it over time, get to the 85,000 extra lives saved. Very importantly, the question is, so what can be done? First thing to understand is that it is a complex society. There are many other public health issues that are often seen as conflicts of interest, still some infectious diseases, a relatively high amount of tuberculosis, but chronic diseases now dominate. And the impact would be particularly on cardiovascular disease, on stroke, oral cancer, and obviously on lung cancer as well. The problem has been that the physician base has never been given the access to the information and data about the benefits of these products. Many still believe that nicotine causes cancer, or that vapes or nicotine pouches may be as bad or even worse than cigarette smoking and the use of oral tobacco products. And so we believe the first step is to activate the physicians, get them more involved, and help them develop their own national reports. Secondly, we believe that the role of fledgling NGOs, consumer groups, that have been the backbone of progress in most countries in around the world, need to be strengthened in Sri Lanka. We already have very solid heart, cancer, and related NGOs working with them to really look at the evidence and understand the benefit would be huge. The role of the dentists becomes even more important in a country like Sri Lanka, given the fact that nicotine pouches could easily displace the current use of toxic oral tobacco products. And remember, this is not theory. This is underway in Pakistan, for example, not too far away, but with a similar cultural root, where these toxic products have now been increasingly displaced by nicotine pouches. And the result, no doubt, will be the eventual elimination of oral cancer. Finally, I'd say that the investment in R&D is important in the medical schools and in the schools of public health, because without sound science, you can't have data to drive the policy. But secondly, without sound scientists, you don't have the advice available in country to inform the policymakers about the benefits of ending tobacco use through the use of tobacco harm reduction. We hope that this report will be part of a suite of reports that we've been privileged to work on across parts of South Asia. And we know that there's increasing interest and support, both from the physician base, from the consumer base, and even from the informed government folk saying, well, if we can reduce the death rate, why don't we do it? And that's the whole purpose of this report. Thank you.
So, as you said, the report estimates that over 85,000 lives could be saved in Sri Lanka by 2060. How do you respond to critics who question the reliability of such long-term projections in countries with limited tobacco harm reduction uptake, both in terms of products, government policies, in today's world?
Well, the good news is that there are very few assumptions that we make that are going to be subject to the vagaries of the long-term concerns. In fact, I'd say that we're probably far too conservative. Basic epidemiology is cooked in because of the known relationship between tobacco use and the outcomes, particularly heart disease, cancer, and so on. We know that the basic data on the reduced emissions of these new products is very substantial, 95, 98% reduction on emissions. We know that the early epidemiological studies and those that have been used to go through the kind of approval process required in the US under the most rigorous standards are showing that we can project mortality and morbidity based upon biomarker use is already starting to come down substantially. Um, so I think that the only real assumption that we're making is if there would be an effective total ban on tobacco harm reduction, that would slow the progress. But again, our knowledge of the history of prohibition and prohibitionist policies suggests that even if government tries to ban these products, the consumer demand remains so high that it's likely that it'll continue to grow the way it has. Remember that many of the countries that are reported on have got bans in place on vapes or whatever. And despite that, we're seeing their growth and their demand happening. And I suspect that in Sri Lanka, we won't have that level of severe ban, and particularly on nicotine pouches. The countries of South Asia, of the Middle East, seem to be moving fairly quickly to recognize their value as being an essential tool in a tobacco harm reduction world.